Thank you very much, Senator. That was a fabulous first panel, so it's exciting to be in the cleanup batter position. Some of you may or may not be familiar with Pew, so for anyone who's not, we do many things, but one of the things we're really focused on is government performance at both the federal and state level. And so I'm actually coming from our state healthcare spending project, which is really focused on three things. First, we're trying to develop as comprehensive a picture as we can about what states are spending on healthcare. And so there's a lot of great information out there about Medicaid, and for good reason, because it's obviously an important and large program. But we're also trying to get at some other categories where information sometimes tends to be less available. So for example, active employee healthcare premiums, healthcare costs within correctional systems, public health, retiree healthcare. And what we'd like to do is develop a 50-state assessment of every state's expenditures and see how those have changed over the last 10 years. We're trying to get at spending drivers so that we can speak to those changes, whether costs have gone up or down. And finally, we're trying to get at effective cost containment measures at the state level. And what we're really interested in, as everyone is, are measures that have shown an ability to reduce costs, but have either at least maintained health outcomes for residents who are affected by it, or maybe even improved it in some cases. So to that end, one of the first areas that we've sort of begun to dig into is Medicaid program integrity, which are efforts to combat fraud and abuse. So just to give you a sense of kind of the scale of the issue, the best data available suggests that at the federal level anyway, in fiscal year 2011, $22 billion in the Medicaid program went towards what are called improper payments. So to be clear, this is not all fraud. In some cases, this is underpayments, it's overpayments, it's payments that went to the wrong provider. It's sometimes payments where there wasn't sufficient information to document it. But the number does comprise fraud and abuse, and it's reasonable to assume that it's a healthy portion of it. So this number is derived from an annual survey that is done to assess for every state on a rolling basis the share of its total payments that go out the door that are deemed improper. And so you can see that here. This is a weighted average of all 50 states. Most recent year, 2011, about 8.1% of payments were found to be improper. The good news about that is that it's actually been dropping in every year for the last 4 years since the federal government began tracking this. But we, and I think every state would agree that as Medicaid becomes a larger and larger budget item for states, really anything above zero is unacceptable, right? So to the extent that money is being diverted away from the vulnerable populations who depend on it and rely on it, we want to help states pull that money back in and use it where it should. So this is sort of where we're coming from. But obviously, as a weighted average, this will give you a sense of where most states sort of fall. So how do states how are states addressing this? The key thing here to know is that the vast majority of state actions really are targeted towards providers. And that may or may not be surprising for some folks. Sometimes we hear about sort of fraud and abuse on the beneficiary end. But from a simple fiscal standpoint, most of the money really winds up on the provider side. And the reason for that is pretty straightforward. If one provider is committing fraud or abuse or acting in ways that the state wouldn't approve of, they're potentially doing that across hundreds of beneficiaries. And so on a systemic level, the dollars there are much higher than perhaps any one beneficiary who's engaging in that. The flip side of that, of course, is that every state needs to ensure that it's maintaining a roster of providers that can adequately care for the people who need it in their states. And of course, the vast majority of them are honest and well-meaning and are taking lower reimbursements that they can receive in the private marketplace to care for very low-income people, very vulnerable people. And so what states need to do is strike a balance between being stringent, making sure that money is going where it needs to go, while not overburdening the vast majority of providers who are acting just as the state would want. And that's really the tricky balancing act that every state needs to walk. So kind of how do states do this? Obviously, it's a complicated process, and there are hundreds of sorts of interventions, but we've tried to really boil it down into three opportunities for intervention. And it begins with provider regulation. And what this essentially means is thoroughly vetting providers before they're enabled to enroll into the Medicaid system, making sure that they haven't committed fraud or abuse before in that state or perhaps in other states. And then, of course, once they're allowed to enroll into the system, continuing to monitor them. The second stage is what we're calling prepayment review. This is, of course, once providers are let in, but before money's going out the door for particular claims, states need to do a good job to verify that the services that are being billed for actually happened, and that they fall within what the state would consider to be appropriate care and have been authorized by the state. And then the final opportunity is really once money has been paid out this is really the time when states have the largest opportunity to kind of mine data on a systemic level and try and identify larger patterns. And so, you know, Mike Allen at lunch talked about the algorithms that the campaign was using to kind of micro-target and look at that sort of thing. I mean, that's essentially the same thing that states do at this stage, and that's because this is when they have all the claim data and they can go after it. Trouble here, of course, is that the money has already gone out the door. So to the extent that states can perform well on the front end and never let in problem providers or make sure that those people are removed before they commit it, that's obviously cheaper and less time consuming. And then there are, of course, kind of cross-cutting measures when it comes to working well with providers and other stakeholders to make sure they know what they should be doing, targeting providers or industries that states find to be highest risk in their states, and those sort of things. And those really underlay all of these types of interventions. So every year, the Centers for Medicare and Medicaid conduct annual reviews of states' program integrity efforts. And they do it on a rolling basis. They do about a dozen states a year. Some of you may know about this. And within those larger reports, states have the opportunity to report things that they're doing that they find to be particularly effective. And among those, CMS sort of puts its stamp of approval on a few of them that it considers to be especially noteworthy, and it's strategies that it thinks that other states should know about and potentially look at emulating. The trouble here is that this information is strewn out across hundreds of separate documents, and it's really not widely known as we've sort of begun to ask various policymakers about it. And so what we've tried to do over the last few months is pull all that information in to a very user-friendly database. And what this will allow you and everyone in states to do would be to search either by state or by type of category of intervention. So for example, if you want to know everything that Texas is doing well to vet providers, you could search by that. If you want to know everything that CMS is recommending when it comes to targeting high-risk providers, you could get at that. If you want to know everything that Colorado or that any state really is doing when it comes to working well with managed care organizations, you can get at that. And so these are all things that states or CMS have deemed to be effective. And there's, in every case, enough information there to get a good idea of what they're doing and then to follow up with the state directly. And this will be something that we hope to have available on our website at the beginning of next year. Just to give you a real quick flavor for what's going to be in here, a few good examples. So for provider regulation, Michigan has a really interesting program where it links enrollment with provider licenses. And so when provider licenses expire, and a letter is automatically generated to them suggesting that they have 60 days to get that license renewed and get back to the state. If that doesn't happen, they're automatically frozen, and no bills, no reimbursements can be made dating back to the point at which their license expired. This is effective in the sense that having a license expire is perhaps a good indication that something might be awry, and it's a good way for the state to kind of flag the issue and sort of freeze things until it has a chance to get with the provider and make sure that money doesn't continue to go out the door. And it all happens automatically, and so it doesn't take a lot of labor costs or time. Prepayment review. New York has an interesting program where it was experiencing that many providers were billing for services that literally never happened because the patients were never even in the office at the time that the claims were billed for. So what it's doing now is actually requiring patients to swipe their benefits cards when they're in particular providers' offices. And it's a very straightforward way to make sure that the care that has been suggested was provided actually could have happened at least because the person was there. Similar to that, they've got a program where when prescriptions are handed out, providers are required to post that within an electronic system, and until they do, those patients can't receive they can't receive the medication at pharmacies, and that can't be dispensed because the state was finding the pharmacies were billing for medication that they had dispensed that there was no prescription given out for. So of course this helps to kind of get at potential substance abuse issues, but it also gets at bills that are coming in when again the prescription was never written. When it comes to post-payment recovery, a really neat example in Colorado is a database that they've created that links critical events that would impact claims to billing patterns. And so they got the idea for this a few years ago when there was a kind of massive blizzard that closed down the roads in much of the state for a few days. But when they went back and looked at the billing claims, they found that home health service claims, which you would expect to probably drop for a few days because no one could get anywhere, in other words, no one could get from house to house, didn't drop at all, which begged the question, well, how did they get there? How could they have gotten there? And when they looked into it, the answer was that many of them didn't. They just billed for it, and they just continued billing for it as they would have. And so they created this database, and they've expanded it to link to any kind of major weather events that would impact billing, any major legislation that you would expect to impact billing, and this allows them to really hone in on those critical times and make sure that when they're doing the data mining I was talking about earlier, they're doing it in an efficient way. And then cross-cutting. California does its own payment error report, similar to the national one I mentioned earlier. And one of the things this allows it to do is identify industries that seem to be of highest risk in the state, which allows it to kind of spend its scarce program integrity resources wisely and really target those that are subject to commit the most fraud and abuse. So just the last thing I would leave you with, one of the reasons, at least from a fiscal standpoint, that this issue was attractive to us is that there's emerging evidence that states who do this well can achieve a pretty impressive return on their investment. And so just a little bit of data to support that. CMS estimates that in 2009, states spent a total of $394 million on program integrity efforts. And they recovered $2.3 billion. And of course, if you divide that, you get a ratio of about 6 to 1. That number wouldn't include averted fraud and abuse that would be achieved through good provider vetting. So it's possible that if you took a wider view, that ratio would be even higher. And so this suggests that as Medicaid continues to kind of compete with education and other resources and become a larger and larger budget item in states, and as states look to kind of see how they can save money without hurting the residents in their state who depend on it, kind of getting at this issue could really be an effective road to take to make sure that, that they're doing well. So I would just finish off by saying that, of course, I want to thank CSG for inviting us to participate, but I also want to say that, this is kind of, we're early on in this process. So, we'd love to hear from any of you about what more we can kind of do on this area or other cost containment areas that would be especially helpful for you and your states as you try and tackle these. So thank you very much.